What's 110? We'll get going. We have 3 people signed up to speak. I'm going to call them in the order that they're on the sheet. I'll call Ms. Faye Brown from the Georgia Academy of Family Physicians. We have the room for Ms. Brown. You're welcome to sit and not have to be on your feet that whole time. There may be questions afterwards, so you may want to consider sitting. Just to know, I'm just I've been in front of committees standing for 3 hours. That actually happened when I was the governor's floor leader, so they like to kick the floor leader around a little while back several years ago, and I was at that lectern right there for about 3 hours. Didn't even know my feet afterwards, so I don't wish that on anybody. Ms. Brown, if you would just let us know. We have 3 people signed up, and I guess what we'll do for members of the committee, just thinking out loud, is we'll take some testimony. I'll ask witnesses to keep their testimony, if they would, to really no more than 10 minutes. That affords the ability for questions. Sometimes a Q&A period can be very brief. Sometimes it can go on, and either way is fine. If I sense that we're going a little long, I'll ask that we go ahead and I'll ask members to go ahead to get to the point in order to afford the other 2 witnesses who are signed right now the ability to testify as well with the same amount of time that's been afforded to you. I think maybe what I'll do is Ms. Bazemore. Ms. Bazemore? Brandy? Thank you. If anybody decides they want to speak, medical professional, we're going to put a copy of the sign-up sheet over there. I'm going to retain a copy so we can keep things moving. We'll go from there. Sorry about all the logistics. Ms. Brown, if you would go ahead and just identify yourself, who you're with, who you represent, your professional background, experience, and so forth, and of course your testimony, and then we'll take it from there.
Of course. Thank you, Mr. Chairman. I appreciate it, and thank you, members of the committee. I really appreciate the time that you've afforded me to talk about this bill. So my name is Faye Brown, and I am the Executive Vice President of the Georgia Academy of Family Physicians. The Georgia Academy of Family Physicians is the membership association that represents all the family doctors across the state. Approximately 90% of all family physicians in the state of Georgia are members of the Georgia Academy, about 2,600 members. Family doctors, as most of you know, hopefully you have a family physician that you see regularly. Family physicians do the entire scope of medical practice, from delivering babies all the way through taking care of patients in the nursing home and hospice setting. And the testimony that I'm delivering today is on behalf of our president. Unfortunately, she couldn't come because of prior patient commitments, and she lives outside of Columbus. So I appreciate you giving me the ability to speak on behalf of the Georgia Academy. And we stand in opposition to this bill. And I will be very brief, and I have kind of a global statement and then a specific statement related to this bill. The global statement is the Georgia Academy has a long-standing policy that, regardless of the issue, knowing that abortion is a very hot topic, and we have multiple physicians who are on both sides of the abortion issue in our debate. But the Georgia Academy has a long-standing policy that we will oppose any bill that will criminalize a physician for doing activities that they are medically trained, educated, and licensed to perform. So that's kind of our wholesale standing policy as it relates to any piece of legislation that would take away from the basic physician duties that family physicians and other physicians are medically trained and licensed to perform. And then specific to this bill, another area of grave concern is that while family physicians do deliver babies, and they're trained to deliver babies, in the state of Georgia, approximately 16% of my membership does deliver babies. So the majority of the babies are delivered in Georgia by the OB-GYNs. And certainly my doctors do a significant amount of prenatal care and early first trimester care. If there is a problem with the mother and or the child during pregnancy, you would refer, a family physician would refer to a perinatologist, someone who's got that subspecialty care for babies and mothers during pregnancy. And what we know is that there's not enough perinatologists. There's one in Macon, one in Albany, and I think 3 in Savannah. So referring to a subspecialist, if there is a mother with a child who needs additional follow-up and care, could well extend beyond the 20 weeks just because there's not enough perinatologists in the state. So it's kind of a specific concern, and then our global opposition to the bill. And that really concludes my testimony, Mr. Chairman, and I'm happy to answer any questions. Knowing that I am not a clinician, I do represent the Academy as their Executive Vice President.
Are you, and I just want to make sure I understood the last statement. I understand the global opposition piece, but then you quickly touched on, as relates to perinatologists,
right.
And who, and are perinatologists members of your association?
They
of
are
the
not.
Academy? Okay.
They would be subspecialists from OB-GYNs.
Okay.
And so they really, if a family physician or an OB-GYN is seeing a pregnant mother and there is a problem or there's some test that shows an abnormality, and so you'd refer them to the perinatologist, there just simply aren't enough in the state, as there are for a lot of subspecialties, and especially once you get south of Macon. So if there was a time determination where you could or could not perform an abortion, the problem with there could be issues where mothers would try to be getting into perinatologists to find out what is the issue, and I think you're going to have clinicians speaking after me that have more specifics. And the 20-week timeline might not be enough time to get a mother in to speak to a subspecialist for additional testing and information about the development of the child.
Mr. Ramsey.
I just want to be clear.
Sure.
So your opposition, boiling it down, is because your membership is trained to perform abortions after 20 weeks. Thus, you oppose the bill and any bill that deals with this topic.
Correct. The Georgia Academy would have a general policy to be opposed to any bill, regardless of what the procedure would be. If you are medically licensed and trained to perform that procedure, if the legislature is trying to criminalize that, if there are punishable penalties for procedures that physicians can do, there is a standing policy to oppose the bill. So yes, you're correct.
So I assume that would extend to any abortion at any time, even much later in the pregnancy.
They're going to follow if they're medically trained to perform a procedure and are licensed to perform it.
Okay.
Mr. Coomer.
Thank you, Mr. Chairman. Excuse me. Just following on that same point, just so I understand, the Georgia Academy of Family Physicians is opposed to criminalizing any activity for which physicians are medically licensed and trained to perform. Is that correct?
Correct.
So y'all would be opposed to criminalizing, for example, assisted suicide?
I'm not here to talk about assisted suicide, but you can take the policy. Your first sentence was absolutely correct.
Okay. So then carrying it forward,
Sure.
I'm assuming the Academy, I'm trying to understand the philosophy that you're coming to us with, but
Okay.
you'd also be opposed to criminalizing forced sterilization, for example.
I'm not here to speak on anything other than this bill.
And you would be, well, you've made a statement that is a
Okay.
general statement, so I'm asking you to answer specific questions about your general statement.
And I appreciate that, but I'm also coming from a perspective that I am not a clinician. And if there were bills before the legislature on any of those topics, and you may have several different examples, I'll be happy to take it back to my leadership and come with with more specific information on any of those topics.
So what I'm challenging, I guess, is the premise that you're opposed to any of these, as opposed to just specifically picking this issue to be opposed to. That's what I'm trying to get at.
No, and I appreciate your point. The Georgia Academy of Family Physicians took up this bill under discussion and review. And as part of our global policy to be opposed to things that physicians are medically licensed and trained and able to perform, they were looking at this bill, which is generally how our association works, is we look at specific pieces. I understand your point.
So to that point, then,
Sure.
was your policy developed in response to this bill? Is that what you're saying?
No, sir. We actually opposed a bill last year for similar reasons. But we have a...
So your policy was formed in response to abortion bills?
Our policy has been a long-standing policy even before I was with the Georgia Academy, which is 10 years. And I can't tell you the genesis of that policy.
Okay. Thank you very much.
Sure. No, that's fine.
Thank you, Mr. Chairman.
Ms. Neal.
Thank you. Along with, I guess, staying within the scope, when it comes, along with Mr. Coomer's comments about the originating reason why you all be opposed to the bill, along with that, you're also here stating that the availability to be able to get to the other doctors is also another reason why the 20 weeks would not be long enough for some women, or if not most women, to get to those doctors just because of where they're located within the state.
Correct.
Okay. Thank you.
Mr. Pack.
Lights not working. Thank you, Mr. Chairman. I wanted to follow up real quickly on Representative Coomer's question. I know you have a blanket, I guess, opposition to any criminalization of medical practice. What if there was a law that says if you perform abortions past 20 weeks that you will not be licensed again? Is that something that your organization would oppose?
Just to restate your question, if a bill passed that said if you performed an abortion after 20 weeks, you would lose your license.
Right. So if you perform that, it's not a criminal penalty, but more of a civil penalty. Is your organization against that?
Without stretching, I'm stretching what I know the leaders have voted on, but yes, I believe they would be concerned about a loss of licensure based on things that they are medically trained to do.
So it's not solely about criminalizing the statute, but it's really about what your organization views as an infringement upon by the legislature of what you're allowed and what you're not allowed to do.
Correct. I see where you're making the distinction, and yes, we also follow very closely the regulations that are a part of Georgia licensure for physicians.
Mr. Atwood.
Questions, Mr. Chairman. Let's do that for Mr.
Gotcha. Mr. Hightower. Mr. Setzler. Are you, I see the light. No? Yep.
Were you present at the last hearing on this bill?
I was not present. I watched it online.
Okay. We talked about a little bit about the absurdity. Well, I would call it an absurdity. Others might take issue with that. That can happen within a medical facility. I presume your doctors are involved in a lot of contexts. I don't know that they deliver many babies these days, but would you agree that it's within a doctor's scope of practice to care for children in a neonatal ICU?
Yes.
Okay, and you would include that as being a very serious part of what doctors do for patients?
Yes, sir.
Okay. And you would agree that it's a very costly, very manpower intensive, very expertise intensive process in a neonatal ICU?
Can't think of anything more important.
Okay. You also recognize that there are children that are 24, 25 weeks gestational age that are born what we would call prematurely, that are in neonatal ICUs. You also recognize that those same children at that same gestational development, rather than having them cared for at the cost of tens of thousands of dollars per week in the same medical facility, could be aborted by a physician. As we talked about before, without getting too graphic, literally, as you probably know, the D&E procedures and some of those DNX procedures that are used. A child that of the same gestational age, the same chance perhaps of living and growing up to ripe old age in another part of the medical facility by a licensed physician could be killed, pulled apart, and rather than having tens of thousands of dollars per week of interventions trying to save their life, a physician can be paid $4,000 or $5,000 to end their life. Do you agree that's the current state of the law?
I did hear the testimony last week, yes.
Okay. And I'm hearing from you that you're comfortable having physicians on one side of a facility spending tens of thousands of dollars per week caring for a life, while their partners, their colleagues on the other side of the facility could be taking a life. And I wanted to kind of frame that as an issue, and I wanted to hear, for the record, your organization's comfortable with that happening within one medical facility?
I appreciate your comments, Mr. Chairman, and as I stated previously, the Georgia Academy of Family Physicians has many, many members who are on both sides of the issue. But for this bill, we do oppose it for the reasons that we stated earlier. I appreciate your points that you made, and I did hear the testimony last week. But, and again, I'm not a clinician, so I'm only reacting to the testimony that I heard and that you recounted. But that is our opposition to the bill that we previously stated.
I guess my question, Mr. Chairman,
Sure.
to the witness, are you hesitant why are you hesitant to recognize that's exactly what's happening and that's exactly the position that you're taking? Because as I understand your position, not seeking agreement, we may leave with a level of disagreement
Sure.
today, but I'm first of all seeking clarity. To be clear, your organization supports the perpetuation of the practice that in one part of a hospital you could have a child of 24 weeks gestational age being cared for at great cost, and in the other part of the facility they're a child whose only real distinction is that they're unwanted by their parents could be pulled apart and terminated and sent out with a medical waste. Is that not the practice and not your position?
Again, I'm not a clinician. I certainly don't work in a hospital setting, but I would say that the Georgia Academy is opposed to this bill for the reasons that I've already stated previously. I understand your supposition that in some hospital settings that both abortions and pregnancies and deliveries and neonatology ICU is going on in the same setting, and I would agree with you that probably does occur in hospital settings. Having not ever worked in a hospital and certainly not a clinician, I wouldn't want to say anything beyond what I've already stated.
And Mr. Chairman, I would just say for the record, there seems to be a hesitance to recognize the practice, and I'm concerned that organizations that represent caregivers are taking a position that to me, when the only distinction is whether one person is appreciated and wanted or not, determines so dramatically and so graphically the difference in their futures. I just share the grave. I would want to express a grave concern to the witness that your organization, as a caregiving organization, supports the perpetuation of the practice we've just described.
Ms. Neal.
In all fairness to the visitor we have before us today, I think being that she's a representative of a group, any additional interpretations that we would want her to account for, she should be at least allowed to refer back to her group before speaking on their behalf. I mean, just in all fairness to her.
It's a judgment that each member has to make. Any further questions for the witness? Seeing none. Thank you, Ms. Brown.
Thank you, Mr. Chairman.
The third letter of this gentleman's name is not clear, so I'm going to mispronounce it. Daniel Weisman? Is that correct? Yeah. All right. And And where it says doctor, I'm saying doctor, so I'm simply reading the name as it appears. And Mr. Weissman, you're with an organization called Medical Genetics, is that correct?
Medical genetics is my specialty.
Oh, I see.
Yeah, I'm a certified genetic counselor at
Okay.
Emory University.
Okay. Thank you. And again, if you could, again, tell us who you are, your background, your experience, education, if you'd like. I mean, just so we get an idea of. One thing that is helpful to us is when we get a pretty good gauge on subject matter expertise on a particular issue that we're dealing with, whether it's this one or something completely different. So you have the floor, and thank you for joining us this afternoon.
Mr. Chairman, members of the committee, thank you for the opportunity to speak with you today. My name is Dan Weissman. I'm a board-certified genetic counselor at Emory Healthcare. If you're not familiar with genetic counseling, I have earned a master's level degree in medical genetics and have extensive counseling training as well. My experience is I've been a prenatal genetic counselor for roughly 3 years now and have counseled over 2,000 patients. My education, I received my Bachelor's of Science from the University of Pittsburgh and my Master's of Genetic Counseling from the University of South Carolina. I have a prepared statement, and then I can take any questions that you guys have.
Sure. We generally try to ask witnesses to refrain from just reading a statement because that's something we could do on our own.
Sure.
To the extent that you can draw from that certainly that's your privilege.
Mm-hmm.
You could keep it to less than 10 minutes so we can have ample time for questions.
Sure.
We'd appreciate it.
So my purpose of being here today is to help educate and also illustrate how the prenatal testing process goes. So as you may be aware that there's basically two broad categories of prenatal testing. The first category is screening. That includes maternal serum screening and ultrasound. The second category includes chorionic villus sampling and amniocentesis. Maternal serum screening is a non-invasive way to get information about fetal development. It is a blood test that measures biomarkers, and it helps provide you with a risk assessment for fetal anomalies. Specifically, it helps detect Down syndrome, trisomy 18, and spina bifida. The blood test is typically performed between 16 and 18 weeks, but it can be performed in the first trimester and also up to 22 weeks gestation. A positive test is not a diagnosis, rather it indicates that you have a risk sufficient to warrant further evaluation, like amniocentesis. A negative test does not mean your child cannot be born with a birth defect or a chromosome abnormality, rather it's just categorized as low risk. Ultrasound is a very powerful tool nowadays. First trimester ultrasound was originally developed to accurately assess pregnancy dates. In the first trimester, between 11 weeks, 3 days, and 13 weeks, 6 days, there's a new technology called nuchal translucency, which measures how much fluid is behind a baby's neck. And that has been shown to be significantly associated with chromosome abnormalities and also fetal structural problems. It, again, doesn't diagnose any problems, though. In the second trimester, between 18 and 20 weeks is a appropriate time for a level 2 or a high-resolution ultrasound, and an ultrasound performed at that time by a skilled ultrasound sonographer can detect approximately 95% of all neural tube defects or spina bifida, roughly 99% of anencephaly, most major congenital heart defects, and also a majority of all a majority of birth defects at that point. And generally speaking, so in the second trimester, if a fetal anomaly is found by ultrasound, then a physician would offer amniocentesis. And amniocentesis cannot be performed until the chorion and the amnion sacs fuse, and that takes place approximately 15 to 16 weeks gestation.
And would you remind us about the chorion and amnion sacs and what those are?
Yeah, so very early, the baby has two sacs that surround it. One's called the chorion and one's the amnion. And they have to fuse together. So basically, it's the bag of water, or the bag that holds the water around the baby. And those have to fuse together before you can perform an amniocentesis, or else it could cause complications. And amniocentesis is performed with the purpose of DNA testing and also helps detect spina bifida. And amniocentesis results take roughly 10 business days to get back. So from whatever time you perform the procedure, final results are back roughly 2 weeks from then. And to help illustrate how this process takes place, so I'll share a patient story with you. My patient was being seen for advanced maternal age, which means that she was over 35 years old when the baby was going to be born. And we first saw her at 12 weeks gestation. And at 12 weeks gestation, we did a prenatal ultrasound in the first step of the maternal serum screening, or the blood test, and the ultrasound in the very beginning of the pregnancy was very normal. We invited her back at 18 weeks. We did another step of the blood test, and the blood test is a two-part process. So after part number 2 at 18 weeks, then you get the results back roughly 5 business days later. And at that time, we did a level 2 ultrasound, which visualized intrauterine growth restriction, so very small gestational age compared to her dates. Also, we saw that there was a possible hole in the heart. So at that point, because of the clinic limits, they have appointment times, you have to invite her back. At 19 weeks, she came back, and we did a fetal echocardiogram, which is basically a ultrasound of the baby's heart, which we found a ventricle septal defect, or a hole in the heart. And at that same time, at 19 weeks, we also got her blood test results back, which were normal for Down syndrome, trisomy 18, and spina bifida. Given her baby's growth restriction and hole in the heart, we counseled her on the possibility for a chromosome abnormality, despite her normal blood testing, and she elected to undergo an amniocentesis at 19 weeks, and at roughly 21 weeks we got the results back, and it was abnormal for trisomy 13. And trisomy 13 occurs where there's 3 copies of chromosome number 13, and the maternal serum screening is not informative for this specific condition. And trisomy 13 can include brain defects, cleft lip, cleft palate, holes in the heart, other significant disabilities. Children after birth oftentimes will have severe mental retardation, seizures, feeding problems, hearing, visual defects, and approximately 85% of them will pass away in the first year. So this story just illustrates how the testing process takes place, but also illustrates, even with exceptional prenatal care, a limit of 20 weeks is not, you're going to go past that limit. So you can diagnose structural defects, you can diagnose lethal conditions after 20 weeks, even inside a patient who's inside a high-risk OBGYN office.
And so you make reference just now to the going after 20 weeks. So the conclusion that you make is what?
Well, 20 weeks is a very arbitrary deadline. It's almost as likely to diagnose fetal abnormalities past 20 weeks as it is before 20 weeks. And oftentimes, if you do spot anomaly on ultrasound, you have to follow up. So it's not a one and done appointment. You may see something, but if you cannot get the correct views, if you can't visualize everything that you're looking for, you have to invite people back. So the process takes time.
Mr. Ramsey.
You cited 20 weeks as arbitrary. Do you think there should be any date at which late-term abortions are cut off or prohibited?
That's not my job.
It's our job.
Mm-hmm.
Okay. Thanks.
Mrs. Cooper.
Thank you, Mr. Chairman. Is it possible, given this scenario of 20 weeks, because I think that, usually you have those tests back before 24 weeks, right?
Yes.
Okay, so normally before 24 weeks you would have had a chance to run the test. If we cut off at 20 and at 19 weeks, because of the schedule, the way women come in, you've had somebody who maybe knows that there could be a serious problem and yet can't have an abortion after 20, is it not possible that you could see an increased number of abortions because people are afraid, women are afraid to take the chance that there is something seriously wrong before you could find it?
Yes. That's not technically my specialty, but people could be making decisions on information that is not definitive. So you could be using bad information. You could choose to have an abortion before 20 weeks, and then further ultrasound could be normal, or it could just kind of demonstrate what you had thought, and the ultrasound could be abnormal.
Can I follow up on that? Because it strikes me, tell me if I'm wrong, it strikes me that you said about making a decision, and we understand what that decision is that you're referring to. But isn't it this type of situation where the mother at that point, isn't this someone at 20 weeks or thereabout that we're talking about who has the intent to carry to full term because they're there? I mean, they're there because, and pregnant, it's their intent to carry to full term, isn't it? I mean, as a practical matter, as opposed to someone who did not have the intent to carry to full term,
yeah, so I mean, with
has
my
taken certain actions prior to that time. Is that a fair statement? I mean, just as a practical matter.
Absolutely, especially with my patient population. These are women who are trying to get pregnant, and maybe they've gone through assisted reproductive technology, so they've spent a lot of time, energy, money to get pregnant. Every woman I've met has the intention of keeping the pregnancy, but information can change the situations as well. So, whenever you give this diagnosis of some sort of major fetal anomaly, it's devastating news, and there's definitely a grieving process. So if you tell a woman that her baby has some sort of problem, she just doesn't flip a switch and say have an abortion. She grieves for her lost child. I mean, there's broken dreams, broken promises, and there's a process to go through to make that decision to end a pregnancy.
Ms. Rand, I'm sorry, Mrs. Cooper, were you done?
No.
Please.
I have another question. Having taught OB and worked with women who are pregnant, Mr. Chairman, I think you're right that all women go into it expecting to have a perfect child, and that is certainly the hope of the family. But I think even at getting close to 20 weeks, when they're faced with the fact that there may be something terribly wrong, having seen this process, they do grieve. It is a hard decision, and it's not one that OB doctors make readily. They don't make the decision for the family. They're there to just give them the facts and be supportive. But I think that a lot of women look at whether there are other children, how bad and what kind of a impact this would have on a family in making decision if they make the terrible decision to have to abort a baby. And I think that is what is so scary about 20 weeks, in that before they have definitive information where they can make a rational, well thought out decision, if that's what they're going to do, that they might choose to have the abortion when it wasn't necessary. And it's never an easy thing with these women. They go through hell in making this kind of a decision, especially those that are in his practice who have often waited years to try to have a family, only to learn that there is likely to be something terribly wrong with the baby.
Mr. Coomer.
Thank you, Mr. Chairman. I just wanted to follow up a little bit on genetics counseling so I can understand your perspective a little better. My very brief research indicates that genetics counselors, the job is basically to advise patients about a particular abnormality that's detected through testing, or maybe even to advise testing be done to patients, and then once an abnormality is determined, to then advise patients as to essentially what that abnormality is, what the technical words actually mean in real terms, and then assist the patient in making a decision as to how to go forward with the pregnancy, whether to terminate or to carry to term. Is that a fair assumption? I mean, a fair synopsis?
Yeah, it is. It's pretty accurate. So genetic counseling has a non-directive. So we don't tell patients, we're not paternalistic like physicians where you should take this course of action. Basically, our purpose is to help bridge the gap between patient and physician, to translate the physician's jargon into basically understandable terms, and then help the patient make a decision, whether it be what testing options to choose or what pregnancy option to choose that best fits them. So it's not paternalistic. We try to be very non-directive and help them live their lives in the manner that they see fit.
So you try not to tell them what the right answer is. You just provide them options.
we can assist in decision making, absolutely, but also, by gathering information about their values, their morals, their religion, how they want to live their lives. Do they want to know if their baby has Down syndrome? If you don't want to know if a baby has Down syndrome, maybe you don't want to do the blood test. But if it perhaps does matter, maybe that blood test is the right test for you.
Okay. And you said you've counseled about 2,000 patients.
Mm-hmm.
And that you also said that every woman you've counseled has had the intention of keeping her baby.
Well, I don't ask that question. So that's just my basic idea.
So you assume that they all want to keep their baby?
Sure.
Okay. And of those 2,000 patients you've counseled, do you know how many of them actually terminated the pregnancy with an abortion?
I don't have that statistic. I mean,
an estimate.
Off my head, a very, very, very low percentage.
So very few of the women that you've counseled actually go forward with an abortion.
Many women that I counsel, their babies don't have any problems.
Okay. I guess earlier on I misunderstood then that I was under the impression that you only take on patients who have an identified problem in the pregnancy, but is that not correct?
No, that's correct. So I guess a person's point of view for high risk. So high risk can mean just over the age of 35 or taking certain medications.
Well, I don't want to define what it is. I'm just wanting you to
those are some of the indications, right?
Yeah.
So maternal diabetes, seizure disorder. So those would all be considered high risk indications. Why I would talk to someone about whatever they're in the office for.
Okay, thanks very much.
Mm-hmm. Mr. Coomer, is your question of the cases that present these situations, what percentage of those
right
generally,
mm-hmm.
Generally as an estimate, do you see where the election is made for an abortion as opposed to carrying to term?
Right, that gets to the heart of my question, Mr. Chairman.
And can you speak to that, Mr.
Yeah, so
Wiesman?
I don't have that specific number in my head. It really depends upon what we're talking about. So is it trisomy 13, something that's considered lethal at birth, or is it spina bifida, where it perhaps is low on the spine and might be corrected by surgery after birth? So it really depends upon what we're talking about. I think in having that woman understand the information, she's going to make her decision based on basically what's in front of her.
Mr. Coomer,
to answer your question, I just don't have that number.
I guess the answer is, I think that's the fairest assessment.
Yeah.
You can't give us an answer to that specific question.
Mm-hmm.
Okay.
Right.
Ms. Randall.
Thank you, Mr. Chairman. One question that I have is, so did I understand you to say that certain tests can be done earlier that can indicate certain abnormalities, but perhaps the most severe ones, abnormalities that could be present, are better found in later tests that can only be done later? Was that right?
That's correct. So earlier in pregnancy, the fetus is very, very small, so it's difficult to look at the anatomy. So in the first trimester, they do the nuchal translucency, which is a risk factor for, say, structural problems. Right. But you're not actually looking at the heart. You're not looking at the anatomy. Only until the second trimester, when the fetus grows in length and size and the proportion of the body parts becomes sufficient where you can actually look at the structure.
And approximately what's the timetable for that? I mean,
so the ideal time to begin
for me to know whether my baby actually has organs or
mm-hmm.
Those things that are vital for the child to survive.
Well, to detect problems with those organs, it would be approximately 18 to 20 weeks. But if you want a detailed ultrasound of the heart, for example, 22, 24 weeks is the ideal time. The accuracy of ultrasound really depends upon the skill of the operator. Mm-hmm. So if you have someone who's very skilled, they may be able to detect problems earlier compared to someone who's not as skilled. So if it's a regular OB, they're probably not going to be as skilled as someone at a perinatology office, a high-risk office where they see those types of things every day.
Thank you.
Mm-hmm.
Ms. Abdul Salam.
Thank you, Mr. Chairman. Dr. Wiesman, when you or interviewing or assessing your patients, is it required that they have health insurance to obtain your services, or do you offer free services?
We don't offer free services. We do offer out-of-pocket with a discount, but we accept Medicaid and also commercial insurance.
Okay. And one of the things that you talked about with the fetal anomalies was that particularly something like the spina bifida, it will show up, I guess, initially between 16 and 18 weeks. Can you also determine the severity of that in later weeks?
Yes.
Okay. And the issue with the hole in the heart, which my son actually was born with, and we didn't detect it prior to birth. But with that, is that something that the longer gestational period will close the hole? Is there a reason?
Well, ultrasound can't detect every congenital heart defect because some of them aren't defects until after birth.
Okay.
And it's natural actually for every baby to have a very, very small hole in the atrium of the heart, but some do just naturally close right after birth.
Mm-hmm. Do you happen to know where Georgia stands on the infant mortality and morbidity rates?
I'm not familiar with that, yeah.
And finally, the ideal time, you said, to be able to see some of these more serious anomalies would be 22 to 24 weeks. But if you have a young lady that hasn't had no prenatal care at all, and they're developed a problem maybe and she had to go to the emergency room, what would the process be at that point?
So if she went to the emergency room, I'm sure they would do an ultrasound there, but emergency room physician is not going to be as skilled looking at the baby compared to a perinatologist who that's their subspecialty, that's what they do for a living.
So women without health insurance or Medicaid wouldn't be able to avail themselves of this at any week?
It depends upon their circumstances and, the doctor.
But they wouldn't have a doctor. Okay, thank you.
Mr. Setzler.
Hey, Mr. Chairman, Dr. Weisman, thanks for coming today. I appreciate your perspective. I want to ask a question that's I'm going to relate here in a moment to directly to the point in hand. Let's take kids in an elementary school setting. What would you in your estimate in a public school setting? How would you classify the dollar expenditure for children that have Down syndrome, special needs versus the average child that's healthy in every way?
So from my experience, and I also work in the general genetics clinic at Emory University, children with disabilities receive much more care, physical therapy, occupational therapy, speech therapy. They're on Medicaid, well care, so they receive a lot more therapies compared to just the average child.
And from an expenditure perspective, be they parents, be they healthcare providers, be they public school systems, there's a large expenditure laid out for them. Is that correct?
Certainly.
Why do you think that is?
They're trying to give their child every opportunity. So, especially, if you say Down syndrome, children with Down syndrome can develop, they can learn how to walk and they can learn how to talk and they can do a lot of the same basic skills that we all can, but they require much more intensive therapy, one-on-one, so they need more time, more effort, more dedication to help them gain those or acquire those skills.
Why do you think people are willing to spend those kinds of resources on kids that are perhaps never going to be able to earn a living for themselves or be gainfully employed? Why do you think those dollars are spent?
Because they love their child.
Okay. And I ask the question because even though you've got children who there's a large expenditure placed on them, there's a lot of outreach and cost and effort to give the child as many opportunities as they possibly can, even though they're genetically they have genetic issues that provide them a lot of challenges functionally. to your point, there great values placed on these children. They could have serious genetic defects. But we've demonstrated as a culture, both as individuals, both as healthcare plans, and as governments, that there is such value in these children, even though they have major genetic issues. They cost much more than the average child to care for. If we take that out of the setting of an elementary school and place that in utero, and we look at a child that has a serious genetic disorder, maybe it's Down syndrome, maybe it's something. As you're in your counseling process, and we look at kids, if the tests come back negative and everything seems to be a go for why we would want to, hey, Mom, looks like everything's okay with your child. Walk me through the conversation you have with parents of kids that have serious genetic defects. Again, in an elementary school setting, they're cherished. We spend lots more on them and are willing and gladly willing to do that. Talk me through that conversation that you have with your patients of children that have potentially very serious genetic defects at 18, 20, or 21 weeks.
Yeah, sure. So once it's identified, we'll sit down and sort of just ask them about what they know about their situation and just gain sort of where they are in their process, and then go over whatever we're talking about. So if we're talking about Down syndrome, sure, we're going to talk about their disabilities, but we're also going to talk about that families who have a child with Down syndrome often appreciate much more different milestones. So you kind of appreciate the little things in life that perhaps maybe a normal family would just regard as normal. And so I think your question is about abortion, and with abortion, so it is technically a legal option, and if it's in the time period where it could still be performed, it'll be presented, but it only matters if it's their own personal option. So I can't live their life for them. I'm not going to be living with the consequences of their decisions. So if they keep the pregnancy, if they have an abortion, once they leave my office, I mean, they're on their own. So it takes two people to make a baby. It takes basically two people to help make that decision. So if we're dealing with a couple or whatever, so they have to do whatever's best for their life, how they want to start their family. So it really depends upon their circumstances.
I understand, Dr. Wiesman, but the question that's really in play here is, this is a lawmaking, we're part of a lawmaking body that's determining what should be legal and what should not be legal. I get it that it's legal today. The question that's really before this body is, should it be legal? And as I look at the lengths at which we take to cherish special needs children in our communities, I mean, in our community, Kennesaw Mountain High School, we have a special needs dance where they bring in kids from all around Cobb County on buses so they can have a high school prom. Because we cherish those kids. There's private money put into that. There's public school money. We go to such great lengths to cherish these kids in life. I'm trying to understand why we as a legislative body ought to make it legal to eliminate these children on its face because they're genetically flawed. They have genetic conditions that's going to make them costly to care for, difficult to care for, or inconvenient for a family. If it's clear we cherish them in life, why should there be a legal difference in utero why a child should be able to be sloughed off as being inconvenient and aborted when clearly there's no fundamental distinction? A child that's able-bodied versus a child that's a special needs child in our schools, we see them as having both the same value. In fact, we're willing to put more resources behind the special needs kids because they are unique. Why should we as lawmakers look at the situation in utero and say these kids are other than, it's convenient to get rid of them? Why should we as lawmakers allow that policy to exist?
Well, I'm not familiar with the moral argument. I don't have the moral argument. I would think of free will, so allowing these people to live their lives in the way that they see necessary. So if you're going to have a child with a significant disability, and if you know this before the child's born, if people don't have commercial health insurance, if it is a single parent family, these are, it really depends upon what their economic, what their social situation is, and thinking. I mean, I've never made this decision before, so I can't say from personal experience, but those are things that I would imagine come into play.
I understand, but and Mr. Chairman, I'll ask Dr. Wiesman this though. I mean, I think the distinction is very clear, that the notion that it's up to the parents and they should look only to their own opinions and their own beliefs in making a decision that affects the life of another. That same argument could be made to a child that's born, that's 3 years old, that's in elementary school. if the child is inconvenient to the family, they've lost their health insurance, the child is a drag on the family, it's very difficult for mom and dad, then by the reasoning that you've suggested, it should be perfectly legal to take a genetically a Down syndrome child or a special needs child that's in second grade and say, you know what, it's best for everybody that they just not live and move forward, because it's challenging for everybody. But by the same logic that I'm following you, that I'm hearing from you, if it's acceptable for moms and dads to distinguish who lives and who dies based on genetic abnormality in utero, I don't see that there's a fundamental difference in life. And I would just ask the members of the committee to consider that we cherish special needs kids, even with genetic disorders in life, just as any other child. Why should it be any different inside the womb?
So, can I respond to that? That's not my logical progression at all. So, born child is different than an unborn child. And, yeah, we love for children with disabilities after birth, but it's very hard. I tell patients, I don't know how a woman feels when she knows this information during pregnancy, because I've never been through that process. So I can't imagine what's going through her mind, and it's very hard to appreciate how much stress, anxiety, turmoil that is, because if you learn that your child has a disability, whatever it might be, so if they have an extra finger, I mean, these are completely different things. You have dreams about your children, and if you learn information that changes these dreams, you know, it's psychologically damaging. So I don't know how women feel, but it's not my assertion that a child who is 3 years old should be given away, or, you know, that child has legal rights.
I guess, Dr. Weiss, what I'm asking you is we have statistics here that show that last year we had children that were 40 weeks gestational age that were aborted, 39, 37, 36, 33 in their 30s, 30 weeks range, many in the 20 weeks range. There's a medical executive, I won't mention them, in the state that had her daughter was born at 26 weeks gestational age and is an adult now. You know, I don't know that there's I'm trying to understand from a counselor's perspective. Mm-hmm. Is there a fundamental difference from a child that's 26 weeks in a NICU or a child that's 26 weeks in a mother's womb? I don't know that distinction is any different than me in a committee room or me underwater in a scuba diving suit underwater somewhere floating around. I think I don't know that my location affects my fundamental humanity. And I think what we're mixing here is does location fundamentally matter for children that are viable? And I think morally we've shown as a culture that we're willing to treasure special needs children like we treasure regular children in elementary school and in early childhood. And I would suggest location's not a difference, and we should treasure them in the womb as well.
Mrs. Cooper.
Representative Setzler, there seems to be a feeling that in the medical profession that they want to abort babies. I can tell you that is not the general feeling of OBGYNs or people who do genetic counseling.
That, Mrs. Cooper, right. the OBGYNs will be heard from soon. If we could just direct to the witness.
Okay.
That would
I'm sorry.
Thank you.
It seems to be inferred that we think people are implying that you want to abort children and that is how you counsel people. To go back over the point that you had earlier about why you can't give statistics, and you tried to go forward in answering that, it's that, am I right, that women are often very concerned. I married at 38. I unfortunately was unable to get pregnant, but had I, being an older prospective mother, I would have certainly sought your counsel or somebody like you on the possibilities, just for knowledge, to know, just like we ask for information on this committee, to give us the facts on both sides, and so that we can make informed decisions. I think that is the kind, am I right, the kind of information, and whereas an older mother, maybe they've been a lifelong diabetic, would even have higher risk and would just want to know what the possibilities were.
Yeah, so nothing is a guarantee, but just to know your circumstances and explain what's happening around you. So pregnancy is a stressful time as it is, but if you have extra doctor visits and they're doing ultrasounds, to just explain what they're doing and why they're doing that.
And I will also, just as before you finish, so that you will know, is that certainly children with disabilities are very close to my heart. I chair the health committee, but not all times do we at the state level act like we cherish them, that many of our foster children who often go without what they need because of what we allocate to them from the state level are ones with disabilities and all, and the people and our children in defects. And often when votes come here to allocate more money for these children that are in such need or under the state care, that allocations are voted down.
Mr. Atwood.
Thank you, Mr. Chairman. Doctor, thank you for being here. I'm just trying to wrap my brain around the testimony that we've been receiving. We're trying to decide whether or not there's a compelling state interest to stop pain at 20 weeks. And if I could go back to your original testimony that you had, where you gave a very eloquent scenario, I thought, with a mother who was pressed up to the edge. How often has that happened in your career, where you really ran up against this timeline, or can you estimate? Or
so with the 20-week timeline?
Yeah, we were going through and getting lab results back and that sort of thing. Yeah. And I was just wondering how often that took place, or if you had an idea.
So it happens as often, these types of things happen after 20 weeks as often as they happen before 20 weeks.
Okay.
I can't break it down 50-50 or 60-40, but it certainly happens just as much after 20 weeks as it does before 20 weeks.
Would it diminish it greatly if the number, let's say, was raised to 25 weeks?
Well, you stop doing these procedures at a time point. So with the blood test, you stop performing that at 22 weeks, and generally you stop performing amniocentesis at 22 weeks, because with amnio before 22 weeks there's a very small risk for miscarriage. It's about 1 in 250 or 0.4%. But if you do it, say, at 24 weeks, well, then the risk would be that instead of miscarriage you would have a preterm delivery. So a child with born at 24 weeks, 25 weeks technically can survive, yes, but they're going to spend months in the hospital and probably have disabilities because of their prematurity. And doctors stop at 22 weeks to prevent a child from being born at 24 weeks and going through that process.
And forgive me, I'm not a medical person, so I'm a lawyer, but so we're essentially discussing roughly a 2-week period here that we're arguing over. Is that what I'm hearing? From 20 to 22 weeks?
Well, I don't think I'm arguing with you.
No. I didn't. Bad choice of words on my part. No, just the opposite. As a matter of fact, you're doing quite well.
So, sure. There is, a period of time afterwards, after 20 weeks, that you would. I just from my own perspective may alleviate concerns for myself, but 20 weeks is not based on medicine. It's not based on what the patient needs. It's from the legislature. It's from you guys. I don't think it's really considering patients when you make a deadline of 20 weeks.
Well, the reason we're considering it, we've had previous testimony that pain is caused to a child, an embryo, at the 20-week period. That's the testimony we received. So we're now trying to make a compelling judgment, one side or the other, what outweighs one compared to the other, the rights of the mother as compared to the pain to the child.
I'm not an expert on fetal pain,
Okay.
so I'm not going to say anything on that.
Okay. Well, thank you. Appreciate it.
You're welcome.
Mr. Coomer.
Thank you, Mr. Chairman. And that last comment may be dispositive of my question. I really wanted to follow on and draw us back to House Bill 954. First of all, have you had a chance to read House Bill 954?
I've read it. Didn't memorize it, though.
Okay. You realize, though, that what we're really getting at here in this process is not so much the philosophical debate about abortion, but about wanting to prevent unborn children from experiencing the physical pain of abortion, and that the research seems very consistent. And in fact, the minority leader was here the last time we had a hearing, and she admitted that it's accepted that at 20 weeks children in the womb feel pain, physical pain. So my question, though, going to what may be in your area of expertise, and if it's not, you can tell me that it's not, but is there any research that indicates that children with Down syndrome or spina bifida or the other abnormalities that you see are less able to feel pain than those who do not have those anomalies?
I can't answer that question.
I said abnormalities. I meant anomalies.
Yeah, I can't answer that question. I'm not familiar with that.
All right. Thank you.
Mr. Pack.
I think several witnesses, thank you, Mr. Chairman, several witnesses have said this, and wanted to ask, why does it take so long to get the results back from amniocentesis?
So with the amniocentesis, you get the sample of amniotic fluid, and inside that fluid are fetal cells floating around there. And when it goes to the laboratory, they have to grow the fetal cells in culture. So they have to divide them up and put them in growth medium so they get a sufficient number of cells, and then they have to stimulate them into cell division. So it takes that amount of time, roughly 10 days, for the cells to grow and then to do the analysis. And if there is a chromosome abnormality, they would do further analysis. So if it's just an extra chromosome, they'd validate their work. If they find some sort of rearrangement, it might even take a day or two longer just so they can look at more cells. So they have to grow the cells and then stimulate them into cell division. And it's at that cell division where you get the best picture of the DNA. So using the staining, they wash the DNA with staining, and that's how you get the best pictures.
I know you said it's more dangerous to do that test past 24 weeks because there's chances of miscarriage, not miscarriage, but forcing a premature baby, right?
Sure.
What is the earliest time you can perform that to get an accurate kind of reading?
Yeah. So when those two sacs fuse, and that typically takes place between 15 and 16 weeks, then you can perform it. So you have to wait until the sacs fuse, because if you don't wait until the two different sacs fuse, and if you put the needle, you could cause tenting, and that basically sort of corrupts the cells that you're getting, because it's putting cells in the needle, and it just makes the procedure a lot more technically difficult. So if they're fused, then they're one sac, and it's sort of like a self-sealing tire. So if you put a needle in the sac and take it out, the sac should just heal over automatically. But there's also a very small possibility that it wouldn't, which comes along with the risk for the amniocentesis.
And excuse me, I've forgotten this. I mean, I have two kids and one on the way. I've been through this a couple times, and my wife is in the danger zone that you mentioned, over 35. In terms of performing the test, my understanding is that performing the amnio test is not something that's recommended unless somebody really wants to do it. Because the advice that at least the OBGYN that my wife and I get counseling from is that, of course, there's always a risk for DNA or genetic deformity, but that's generally not prescribed or advised to do that because of the danger to the baby. Am I right about that?
Yes and no. So the American College of Obstetricians and Gynecologists recommend it for every pregnant lady, but a lot of women say any risk is too much risk. So a lot of women just sort of eliminate the option themselves because it doesn't sound like a fun procedure and it has that very small chance for miscarriage. And usually women only perform it if there's a very good reason, whether it be peace of mind because of their age, or if there is something found on ultrasound. Generally speaking, there's usually always a reason why you do that test, not just because it's there.
If I might follow up one more time. Out of it looks like the test should be generally performed between 15 to 16, all the way up to maybe 21 or 22 weeks. Is that right? Out of that, what percentage do you think of those tests, amnio tests, occur prior to 20 weeks, and what percentage of those tests occur after 20 weeks?
Well, I don't see every single patient that goes through the clinic, so I only see this subpopulation of patients, and I would say that a majority of them probably do occur right around 20 weeks. So, I haven't been able to answer every question.
Do you know why? When you could do it starting at 15 and a half weeks?
Well, it's when you get test results back. So, if you do the second part of the blood test and you get test results back, say even you get results back, you do the blood test at 17 weeks and you get results back at 18 weeks, again, it's not a snap decision to undergo an amniocentesis, so women have to consider their options, whether or not the risk is worth it, and then you have to get fit into the clinic. So, they just can't clear their day because you want an amniocentesis, so they have to fit you in the appropriate slot on their schedule, that could be the next day, that could be the following week. It really depends upon, how busy the office is.
Thank you.
Last question for this witness, Ms. Neal.
Thank you, Mr. Chairman. I guess my question is in reference to when I heard some people mention why does it take so long and things of that nature. Can you just let us know if we're getting into dangerous territory when we start trying to put certain timelines on doctors that practice this type of medicine or these procedures, and just kind of elaborate on the importance of them needing as much time as necessary to make a proper and accurate decision on if an infant should be born or not?
Well, the pregnancy doesn't go by how you want it to. So, I see a lot of high-risk patients, but, I see a very, very small fraction of pregnant ladies. So if you're not a high-risk pregnant patient, if you're just a normal woman who's pregnant, you're probably not even going to get an ultrasound at 16 or 18 weeks. Your regular OB maybe do it at 20 weeks, and then you're already at your cutoff. So, the patients that I see are followed very, very closely, so they're identified right when they find out they're pregnant. But even if you're just a low-risk normal pregnancy, you may proceed up until 20 weeks, and then you're past your timeline. So, the office schedule, how doctors operate, it is not geared towards a law stating 20 weeks you have to find out all the fetal information, and then you take options off the table. So, it's just not how we operate. It's just.
Is it realistic?
It's realistic for some people, but it's not realistic for a lot of people. So, if there are people in rural Georgia and there's one doctor in their county, they see that doctor, then they have to travel a long distance and they have to get fit into clinics. So it may be realistic for a person in the metro area, if there's a lot of physicians around you and that you're pregnant early on, but a lot of women don't know that they're pregnant in the first trimester. A lot of women live away from doctors. They have to travel a great distance. It takes a lot of time and energy and money to get to the doctor's office. It's not realistic for, I would say, a lot of people.
Thank you.
Mm-hmm.
I said it was the last question. I lied. Mrs. Cooper.
Just a statement to the committee. I can provide you with a map of Georgia showing you the numerous counties in our state, all over the state, north, south, east, and west, that have no regular OBGYNs, and where women are driving 100 miles to receive care, and those obstetricians and their offices are just overloaded. But we have a huge shortage of OBGYNs in the state.
Thank you for taking the time.
Thank you.
To come down here and share your opinion with us and to answer the battery of questions. We appreciate it.
You're very welcome. Thanks.
Before I call on the last witness, which will be representative of the Georgia OBGYN Society, is there anyone from DCH here? Mr. Chairman? Yeah. I've just got a quick question, and this is, and if you're not in a position to answer this, I understand. I just had a quick question about the reporting requirement. There's a reporting requirement to DCH that's mandated in this bill. I'm under the impression, subject to getting educated otherwise, that there's already some sort of reporting requirement to another state agency. I'm curious as to what DCH's take is on that aspect of the bill. Is it duplicative of a reporting requirement that's already occurring now? And if you want to answer that now, you can. I would counsel you not to, but to go ahead and to seriously to go ahead and get some feedback on that, because the committee's interested in the logistical issues that go along with that. If we have an existing requirement that works, and I don't know that it does work, but if it does work currently, fine. If it needs to be amended or altered, obviously it's something I'll talk about with the author as well, but I'd like to know what it is from a DCH perspective. If we can get that answer back in the next day or two, that would be helpful.
Absolutely.
Okay.
That conversation has been going on with the bill author as well, so we'll certainly do that.
Okay. Thank you very much, and I'm sorry to put you on the spot. Okay. Last witness today will be Dr. Ann Patterson, representing the Georgia OBGYN Society. We've got about 40 minutes left in the room, so Dr. Patterson, if I could ask you, as I have with the other witnesses, to limit your comments to about 10 minutes or so. You don't have to do 10 minutes. And then, and if you would, go ahead and receive questions from the committee.
All right, sir.
Thank you for being here.
Thank you. I practice maternal fetal medicine, or as it's been termed here today, perinatology. Let me just walk you through what happens. If you are in medical school and decide to do OBGYN, it is a 4-year residency. There are 3 subspecialties, and if you choose to go into one of those, that is GYN oncology, which deals with the cancer, female cancer patients, reproductive endocrinology, helping people get pregnant or dealing with endocrinological problems that a woman has, and what I do, maternal fetal medicine. There are 3 years post residency. And what we do in maternal fetal medicine or perinatology is to take care of women who have any type of medical or surgical problem while they're pregnant, because maternal physiology is different, and or any baby that has a problem prior to the birth of that baby. So we see the complications of pregnancy. And it has been stated here earlier today that there are not very many of us in the state, and that is true. And I have practiced here in this type of specialty for 25 years. And I unfortunately do get often to see patients who really do have a heart-rending, difficult problem that we have to try to help them work with or deal with. Prior to starting practice here, I studied fetal physiology at the University of Oxford in England. And I want to speak a little bit about fetal pain. There is no fetal research done in this country, has not been legal for over 30 years. The research that is done in either Europe or in the Commonwealth countries, by and large. And there are some really good recent articles, juried publications who speak to this. There's one in the Journal of the American Medical Association that's pretty comprehensive. It's fairly recent. The Royal College of Obstetricians and Gynecologists in Britain published a consensus paper in, I believe, March of 2010 that discusses some of this research. And it's pretty well known, both from looking at MRI and histochemical studies, that between 24 to 25 weeks, the neurons advance into a subplate into the brain, and they sit. And past that, then they begin to grow into the cortex. So prior to 24 weeks, we can pretty well identify that those pathways are not present. That would identify pain. There are some studies out of Europe that give us 28 weeks before that is possible. And what we need to remember here today is we are the only mammal that is born with a brain that is still developing. And for those of us with teenagers, we're really glad that continues into the 20s, especially me. But our brains are not as developed as all the other mammals, because if they were, we would never be born. So it's a compromise of our evolution. But brain development is still progressing. And we do not think, from the studies that are available, that we really have good pain pathways probably to 28 weeks. Some studies are suggestive at 24. But that is current research. That's in juried publications. We can provide that to you. So I think that speaks to the question that I think you had about when would the fetus be able to detect pain. And I think 24 weeks would be the onset that that's possible. Now, I have to tell you that not every baby develops at the same rate, because the placenta, if you like the heart-lung machine that's on bypass for the baby, develops as well, and some of them work better than others. But it's the lifeline for that baby, because the baby's on fetal circulation, and the mother's placenta provides the nutrition, the oxygen, and all to that baby. So babies develop differently because the placenta may function differently. And we talk about really tiny babies that are born and survive. That's true, but we often call them our mighty mites. They're the babies who have had some sort of stress from the placenta or some sort of stress from the mother's body, and they are a pound and a half, and they come out and they scream and they're doing great. That's really not the same scenario as a baby that's just a pound and a half and really premature. Those babies truly struggle because they haven't had the stress that the others at the same size have. So you have to realize, and why I use that example is, every pregnancy is different, and often the outcomes are very variable. So I deal with the variables. It's really great when I get a patient who comes to see me and we look at everything, or we do an amnio and we can tell them, it's great, go home, you don't have a problem. I won't tell you it's rare, but it is not common either, but it does occur. And I have to deal with it, as do my colleagues who do the same thing. Is the baby that is in front of us that really has a serious problem? And I think the geneticist spoke eloquently about the process of sitting down with the parents, and we sit down with the parents as well. And often we don't see them till after 20 weeks because the standard of care in the state for just a routine scan on a mom, healthy pregnancy, is 20 weeks. So then they come to see us. We repeat the scan because we can do a high-level scan. And then we have to counsel them about what we see. Do we want to do an amniocentesis? They often will see the genetic counselor. And then, depending on the results of the ultrasound, the amniocentesis, the genetic counseling, all of those pieces put together, as well as the maternal health, we talk about what they're facing. And it could be anything. Now, I have to comment on Representative Setzer, I believe's comment about children with disabilities. Often children that are born that have disabilities may be something that we, with all of our technology in medicine, cannot detect. Ultrasound may not pick these up. An amniocentesis might not pick this up. I, too, am a mother with a child with a disability, and he was perfectly healthy. He had, as far as I knew in pregnancy, he had many ultrasounds. He had an amniocentesis, and as he grew, it became clear that he had a disability. And so I have learned how to deal with children with disabilities, but that's not the cases we are really looking at. Those are things we can't always see. We're talking about the patient who comes in who definitely has a genetic abnormality that's incompatible with life, or it may have a congenital anomaly that's incompatible with life, the liver outside the body. We're talking about exceptions. We're not talking about the general run-of-the-mill, gee, maybe this doesn't look to suit us. That's not what we're dealing with. We're dealing with true, heart-rending, difficult, horrible decisions. No mother, and most dads, don't want to discuss having to end a pregnancy because it's incompatible with life, or if she continues the pregnancy, that her life may be in jeopardy too. And so these are the cases that we often get after 20 weeks that we have to help these parents walk through a really terrible time to make a difficult decision. Now, make no mistake about this. I am not an abortionist, but I am here to help the women of this city and this state cope with the problems that they are faced with as they deal with the difficult, heart-rending decisions that are minimal. If you look at the numbers, there are not that many every year, but they do exist. As I said, they are not common, but they are not rare. And I want to emphasize the fact that I am not an abortionist, and I feel very strongly about this. And I sit in the hot seat every day with the patients that I see. I have another son whose mother came to me for me to certify that she had an abnormality, which she did not. And she had scheduled a termination in another state, far past what Georgia would consider appropriate. And I said, he's fine. He's going to be here with us. And if you ever consider adoption, I would consider that. As it turns out, she did. She asked me if I would adopt her child, and he is my youngest son. So I want to make it very clear I'm here to help the women of the state with their problems. And I find that 24 weeks is the first time I think you should consider fetal pain. I think that we, as a legislative body, and I'm part of your constituency, feel very strongly that women should be able to look at things medically and appropriately and have the right chance to make the decision that is best both for them medically and for their child medically. And I have to add that D&Es are not done at 24 and 25 weeks. I've been on the staff of 8 different hospitals in the state. I know of no hospital that does it at that term. So I did want to clarify that.
Let me ask you, I mean, I've heard, just as a layman, I've heard testimony about fetal pain at earlier stages. Now I'm hearing it at no earlier than 24 weeks. And
that's really good scientific evidence. We'll be glad to provide you with those articles.
Well, that's my point. I mean, we get articles from this side, and then we get articles from that side, both of which will demonize the other's findings.
Well, I'm not trying to demonize anybody.
Oh, I know
I'm just
you're not.
looking at the science.
Well, I know.
And
but
obviously,
if I could just finish my question,
sorry.
and that is that we're sitting back here as laymen, and we get the battle of the experts, and battle of the academic articles about, well, fetal pain can be felt here. No, it can't. It can't be felt until this time. That puts us in a position, and so I guess my question would be: don't we do better to err on the side of caution as it relates to pain?
Not really, because you think about this. I mean, if you just are talking about pain, I submit that a vaginal delivery for the fetus is painful. I suspect that child has quite a headache.
Okay.
Okay. Now, let me give you another scenario. For instance, you have a baby, I see a baby, who has something called posterior urethral valve syndrome, more common in males than females, because of the urethra. And if it's a partial obstruction, fluid will pass around the baby and be in the amniotic fluid. If it is a complete obstruction, the amniotic fluid is no secret, it's baby urine. If there's a complete obstruction and there is no urine passed and the amniotic fluid is minimal or non-existent, the baby will die from 2 reasons. One is the fluid in the bladder backs up into the kidneys and destroys the kidneys. So that's a bad thing. But even worse, the fluid that is in the amniotic sac is used by the lungs for practice breathing, but it actually does more. It provides the fluid that the baby breathes in and out so that the alveoli in the lung are soft. In other words, they're soft like this. So when air starts to exchange, when the baby is in the extrauterine life, the lungs are compliant and soft and can move. If there is no fluid, the lungs are hard and stiff, just like your knuckle would be. And trying to ventilate those babies is almost impossible, if not impossible. And so they die usually from the lack of exchange of air. So we can do something about that. This is a patient that I would see. And so what you do is you put a pigtail catheter into the bladder, and you pull the other end of it out on the outside of the baby to drain the bladder externally. The catheter is a little smaller than the pencil, but not much. Mom is not anesthetized. A lot of times we'll just use local in that area. The baby has to be lined up right. I put the introducer in. It's a lot of pushing. And once it's in the right spot, we drop the pigtail of one side out, pull out, get it out on the outside of the baby, and pull the introducer. And so it's got a double pigtail. One inside the baby, one on the outside of the baby, and it's the conduit for the urine to come out, which will then save the kidneys and save the lungs. Those are some of the procedures that we do in my specialty to help a baby survive. We don't anesthetize the baby. When I'm doing a intrauterine fetal transfusion for, say, the baby has, we give RhoGAM today, so there are not as many, but you can be Rh negative and sensitized, and the mother's blood cells can chew up the baby's blood cells. If you have that situation, then you have to give the baby transfusions periodically throughout the pregnancy. And we sometimes do some sedation for mom just to get the baby to hold still so we can hit a really tiny spot. And the babies are really tiny a lot of times when you start doing this. So you're hitting with a needle a really small area. You just want the baby to be still. We do not anesthetize for that.
Ms. Neal. Ms. Bentfield.
Thank you, and thank you for being here. Knowledge and experience and also compassion. I appreciate that. You testify that every pregnancy is different. So knowing that, is it fair to have a bright line test of 20 weeks?
I don't think so, and I think that's a great question because women are different. It's nice to do a scan on somebody who's nice and slender, who scans very well, and the baby's in a great position. That is not always the case. At the moment, I have 2 women who are over 400 pounds as my patients. And let me tell you, I will never even tell them by the time they get here what the heart of those babies look like. Because physically, it's really difficult to scan, even if I'm trying to scan vaginally, which sometimes I try to do. So not everybody is created equal, and scans can be difficult to do. So it's very hard to put an early date on something like this and be realistic about us being able to give good advice. Later is better.
If I may ask a follow-up question, Mr. Chairman, is it fair to say that the majority of the late-term abortions, the fetuses usually are going to have severe fetal abnormalities?
I don't know of any termination, and as I say, I practiced this 25 years, that has been done, that's been later, that has not been a significant anomaly that would not be compatible with life. This is not something that's done because somebody just wanted to have a termination. That's not what this phase of medical care is about.
So in the cases that would be addressed by this bill, we're talking about fetuses with severe abnormalities. My question for you is, knowing that, is there a difference in the ability to experience pain by a fetus if that fetus does have developmental disabilities or abnormalities?
To my knowledge, there are no studies that address that because you'd have to have a number of fetuses and infants to study. So not that I know that we have ever done that. The studies that I'm referring to that have been done in Europe have been very consistently done in an adequate number of patients to try to elucidate how quickly the neuronal tracts develop, where they stop in the brain, when they cross, when they begin to progress. And you need an adequate number of people to look at that in. So I don't know that that's ever been addressed.
Thank you.
Mr. Coomer.
Thank you, Mr. Chairman. Doctor, you mentioned that you do not administer anesthesiology during fetal surgery. Is that you never do that or have never done that? Is that your testimony?
Not specifically for the fetus. Now, fetal surgery is a broad term.
Okay.
When we're doing a procedure on a fetus, it could be classified with that. I tend to think of fetal surgery as an open procedure when we are actually opening the uterus and operating on the fetus.
Okay. And have you performed those kinds of surgeries as well?
Yes, but not here.
Okay. And when, you mean not in Georgia?
When I was at Oxford, yes.
Okay. So in Europe?
Yes.
Okay. And you...
and at those times, the mother was under general anesthetic, and that does cross the placenta.
And so the child was also anesthetized through the mother's general anesthesia.
But you have to realize that's when you're opening the uterus to do something.
Okay.
Okay.
And so my question is, why would some doctors anesthetize the fetus during fetal surgery of any kind?
To my knowledge, it is done, if any, very, very rarely. You lose a lot of landmarks. You're dealing with something very, very tiny. The procedures that we do, I've described how we proceed, and opening the uterus and doing fetal surgery, to my knowledge, is not even done in Georgia.
Okay. You mentioned earlier that no studies had been performed on any human fetuses regarding pain in the last 30 years in the United States. Is that
That's correct? It is illegal in this country.
Are you aware of any other studies in Europe or other places that do indicate there is evidence of fetal pain at let me back up just a moment, because there's one other point I want to clarify, because we keep talking about weeks.
Right.
And my understanding is there are two sets. You can use a
correct.
different measurement.
That is correct.
There are weeks post-fertilization and there are weeks gestation, and those are not the same number of weeks.
We use gestational age in medicine.
And that's about.
And I would urge everybody to stay on the same page. The definitions and the weeks were defined by the World Health Organization many years ago. They've stood the test of time, and I would urge everybody to stay on that same page. It makes it clear.
Okay. So if we're talking about, so today when you've testified about numbers of weeks, you're talking about weeks gestation.
Gestational age, correct.
Which is about 2 weeks more than or higher than post-fertilization. So if we're talking about post-fertilization, 20 weeks post-fertilization, that would be 22 weeks gestation.
Say that one more time. I'll be sure we're right here.
If I say to you, if I'm talking about post-fertilization weeks,
okay,
and I say we're discussing 20 weeks post-fertilization,
right,
that's the
20,
same
that's
thing as saying 22 weeks gestation.
Right.
Okay.
But anything you all pass, I would urge you to use gestational age, because that's consistent in the medical community, and that's what we will go by and work with, and I think it makes the most sense.
So when witnesses testify, well, let me ask you this, is it generally accepted in the field that when a physician or a person who is operating in the field that you operate in discusses weeks of pregnancy, they're generally talking about gestation weeks?
That is correct.
Okay. So is it safe then to assume that people who've come and testified before us who've said references to 20 weeks or 21 weeks, we haven't, and nobody else has clarified this point so far. So is it safe to assume that those folks are talking about gestational weeks?
I don't know that I can answer that question, because I'm not sure I've been privileged to what they've said, so I can't really clarify that. There's testimony, but I would urge everybody to stay, with gestational weeks, because that's what we use.
Okay. And then getting back to my previous question that I interrupted myself on, are you familiar with studies in Europe related to humans that demonstrate a fetus at 22 weeks gestation can experience pain while still within the mother? In other words, this child's not been born yet, 22 weeks, fetus. Can that fetus feel pain? Are you familiar with studies that say that fetus can feel pain?
I have looked at the really recent research that's been done on this, and I do not know of any that demonstrates that.
So, to your knowledge, there are no studies recent within the last, would you say 2010 would be recent?
2010 should be recent. I don't know of any in the past 5 years that have demonstrated fetal pain that I think are, well, I've not seen any that I think demonstrate fetal pain at that stage.
Okay. Are you familiar with a journal called, I think this is a journal, not a title of an article, but a journal called Best Practice in Research Clinical Obstetrics and Gynecology?
No, sir.
Okay. You are familiar with the New England Journal of Medicine?
I am.
Actually, that was a 1987 article. Let's see.
I mean, I think the techniques that we, obviously medicine marches on and we get better and better at things, and I think the techniques that have looked at the fetal pain in the recent past have been much more sophisticated using MRI than we have ever had before. Okay.
And so you're familiar with a journal called International Anesthesiology Clinics?
No, sir. I'm hard-pressed to read all of my journals. I don't take on anesthesia. I have to tell you.
Okay, that's fine. That's all I wanted to ask.
Thank you. Mr. Setzler.
Thank you, Mr. Chairman. Doctor, thanks for coming today. Wanted to ask you, are there, again, I'm trying to draw some parallels here for purposes of clarity and context. Are there, you talked a little bit earlier in your testimony about conditions that are incompatible with life. If you were operating in a trauma setting, I don't know if you've ever worked extensively in a trauma setting or not, but assuming you've got certain certainly a greater level of expertise there than I would. Are there conditions that that doctors find in a trauma setting where folks come in where their conditions are so grave they're inconsistent with life?
I'm sure. I don't know if you're referring to a mother who's pregnant who comes in whose situation is inconsistent with life and pregnant. Is that what you're referring to?
No, ma'am. I'm talking about whether you're in a military theater of operations where someone has been victim of an explosion, or even something that's some kind of accident here in Atlanta, whether it's a crime-related shooting or explosion or just a freak act of nature. Someone rolling into an emergency room where they're just severe head trauma. There's major organ damage. It's just a matter of time, seemingly until they're going to die. Perhaps somewhat of a painful death. I mean, can you imagine there being circumstances like that in a trauma setting that would be inconsistent with someone living?
I'm sure any trauma center would have patients who succumb or are near that when they arrive. I could imagine that.
Do you know if it's a practice when folks are in perhaps severe pain or in a trauma setting that's inconsistent with life? Do you know of any practice that's accepted today where a physician counsels perhaps with two other physicians and says, I want a second opinion on this, but this person really has a miserable future in front of them. They've got a terrible set of circumstances. Let's just go ahead and put them out of their misery and let them go. And let's assist them in dying because you know what, they're just not going to make it. We think their condition's inconsistent with life. But are you aware of any standard of care in trauma medicine where that exists?
No.
Okay. And I ask that because I've heard your contention that, and it's not lost on us. There's some very serious conditions of children in utero. I'm trying to understand how a very difficult, perhaps grave medical condition of a child in utero that's one could say is inconsistent with long life or life, how it's in the patient's best interest to end their life. Help me understand that.
I will. I'm going to go back to your trauma question, though. I have been called twice to an emergency room where the mother was suspected to succumb, and they were trying to keep her alive because of the baby. And I have in my life performed 2 what we call agonal cesarean sections. They're ventilated, they are not anesthetized, and we get the baby out as fast as we can to try to save their life. So that does occur, and I have done 2 of them. One survived, one did not. But those situations do occur, and once the baby was out, they quit ventilating.
And I appreciate that. That's some of the heroism we see in medicine. My specific circumstance, though, is not with a pregnant woman that's in a trauma center. It's just any patient in a trauma setting that's part of their head's blown off. I mean, there's some awful things that we can see with the marvels of modern medicine. We've been able to save soldiers in forward deployed theaters that even a generation ago there's no way we could have saved them and had them recover. I'm just trying to understand how it's, again, I think it's clear to everyone in the room that there are people in trauma settings that have medical conditions that are inconsistent with life, but we do what we can to save them. Perhaps at some point the doctor says that I've done all I can do, and natural events take course and the person dies. I'm trying to understand how in a setting in utero, how there could be medical conditions that are inconsistent with life that leads physicians to say, it's in the best interest of this person to...
Okay, I can answer your question. The human body often perceives in its own way that there is something wrong. Okay? People have miscarriages. A lot of the times when you look at the chromosomes of the miscarriages, there is a genetic defect. Body sometimes can sense that. A pregnancy, just so you'll have a reference of what's going on with a pregnancy. If we took a kidney as different from our bodies without doing any testing, without getting any compatibility, and we just put an extraneous kidney in somebody else, that person would reject it. And so a pregnancy, a baby, is often immunologically quite different from the mother. And so her immune system is somewhat blunted in ability to try to carry that pregnancy. And even in the best of situations, we sometimes get something called preeclampsia, which is to some degree like a rejection reaction. And patients can have hypertension, they can have renal failure, they can have liver failure, they can have blood disorders where they don't clot. And worse, they can have seizures, and it becomes eclampsia. What can happen is, in a situation where there is a severe defect in the baby that the body senses, moms can sometimes go into early preeclampsia, which necessitates delivery, and can actually have her life put in jeopardy by carrying something that can be that's incompatible with life and can start this cascade of effects. So pregnancy is not a benign condition.
Indeed. And would you consider that circumstance a life-threatening condition for the mother?
Yes, it is.
And I appreciate that. I'd like to call your attention to the bill. On lines 64 through 75, there's a section that speaks to termination of a pregnancy that would pose a greater risk of death to the pregnant woman. If she had, and I could read it. I'm sure you've read it.
I don't need you to read it to me, but I do want to emphasize that is not the case in every pregnancy, but it is the case in some. So it is often wiser, both for the mental health, emotional health, and physical health of the mother, to address the circumstances at hand as opposed to ignoring them and hoping she doesn't get preeclampsia. She needs to be well informed. She needs to make the appropriate decision for her, and we as physicians need to be able to guide her into what those are.
But again, Mr. Chairman, if it pleases the chair, with all due respect, just for purposes of clarity, this bill very clearly, and I appreciate the author being, I think, doing what I feel is a pretty good job. I think a very good job of addressing circumstances where there's significant physical harm to the mother or death of the mother. That's addressed in this bill. And I believe as well as this can possibly be, and I think adequately. So taking the case of the health of the mother, the physical and life-threatening conditions of the mother off the table, because that is adequately addressed here. Again, taking it right back to the thrust of how it can be in the best interest of the individual who's threatened with a life-threatening condition to go ahead and say, you know what, we're going to end this child's life because somehow it's in their medical best interest. We would never consider that in a trauma setting. But what we're talking about here is someone that has a condition that one might deem incompatible with life, that a licensed physician is going to kind of sort of intercept that process and go ahead and make the determination to end their life.
I would submit to you that there are trauma settings where people do not receive care because it's inappropriate to continue for certain situations. As I said, with the agonal cesarean section, the woman was ventilated strictly until we could get the baby out. And that was a situation that was not going to be compatible with her continuing to live. It was not going to happen.
Yes, ma'am. And I would suggest it's very clear the author's intent is that if the child has a condition that's not consistent with life and they don't make it, then that's not addressed in this bill. What's addressed in this bill is specifically a medical abortion that's performed to end the child's life if a determination has been made that for any reason that they're not going to make it, or that the parents decide that the risk is greater than the potential payoff. I just want to be crystal clear. We're not talking about children that die on their own in utero. We're not talking about circumstances where the mother could have a serious medical condition. This is all about the decision, should the decision be legal in the state for a child to have to be terminated, have their life terminated through abortion. That's what this is about.
Well, I want to point out you don't always know if someone's going to get preeclampsia. You don't always know if the mother's going to get really quite ill. And sometimes when mothers are quite ill, the whole thing becomes much more complicated because you're dealing with trying to save her life and do a surgical procedure of some kind. And that's a much more complicated scenario. So you're trying to be as intelligent as you can be, giving the parents all of the information and the medical abilities that are available in the world so that they can make the appropriate decision for them. This is not about just terminating a pregnancy after 20 weeks because that's what I wanted to do.
And just to be clear, on line 67, it does give doctors, in their reasonable medical judgment, termination of pregnancy in that manner would pose a greater risk of the death of the pregnant woman or of substantial and irreversible physical impairment. I think that's, and to your concern, I think that's well addressed in the bill, Mr. Chairman. That's all I got.
Mrs. Cooper.
Thank you. Thank you for coming to testify. I would like you to tell us some of the anomalies that you consider that are incompatible with life. I know I can think of a couple, a baby with no kidneys, a baby with no lungs. There are other ones that
Right. If the internal organs are exteriorized and not inside the abdominal cavity, those babies don't survive. There are some exceptions. If the bowel is out, sometimes you can help those babies survive by building a silo and waiting. Not always. But bowel is one that you can repair. If there are anomalies of the brain that are really high, as well as anencephaly, those babies don't survive. There are multiple trisomies that don't survive. The most common, obviously, is trisomy 21 or Down syndrome, which we're all familiar with. And by and large, those children do survive, unless they have really significant heart anomalies, which is a complication of that. But that's something we can often detect on ultrasound if it has a heart anomaly that's not compatible with life. Those are, any of the vital organs that are not developed and cannot be developed over time, and or some of the genetic abnormalities that are not consistent with life, other than trisomy 21.
Okay, and in your exchange that just passed, I mean, if a mother is carrying a baby that, let's say, has no kidneys, and in one of the complications and things that could happen, even though they may not have preeclampsia, can they not sustain severe renal damage and other things that might not be detected right away, and like you said, would also, if you have to wait until that, I guess we're talking about preventive care, which we all talk about, and trying to keep bad situations from occurring.
Right. It's always better to be intelligent and deal with a situation than try to be clever and get yourself out of a bad situation. If you have a baby that has no kidneys and none are going to develop, and renal transplant in the neonate is not done, that baby is not going to survive. The mother is at some risk. I have seen patients choose either way, some to end the pregnancy, some to carry that pregnancy. I think it's a very personal choice, but that all those children succumb.
And the last question, isn't the complication and possible death rate pretty high if a patient goes into eclampsia and has to have surgery? I mean, doesn't the surgical risk go sky high for the mother?
Right. And I would like to also say that Georgia is the largest state east of the Mississippi. We have 39 counties without any obstetric care. We are 41st and 43rd out of 50 states for preterm birth and low birth weight babies. That's terrible. So people in my profession work very hard to try to help us improve on those statistics. But women who often are not privileged to be in metro areas often do come late to care, and if they have difficult situations, it's often later that they have to be dealt with.
Dr. Patterson, we appreciate your coming this afternoon, giving us your perspective, and also, most of all, answering all the variety of questions. We have about a minute left in the room. Chairman Rogers is outside the door looking at me with a funny look on his face, so that means it's time for us to vacate the room for the next meeting that's scheduled. We will go out and we will put out a public notice on the next hearing on this issue in as timely a manner as we can, so that folks have notice. Thank you for coming. We're adjourned.